Hello everyone, my talk is on ACL and PCL reconstruction in one sitting. ACL and PCL can at the same time can injure mostly with a high energy injury like traffic accidents, fall or some sports injuries, but mostly accompanied by one or two collateral injuries like posterolateral corner or MCL. And these reconstructions at the same time necessitate longer tourniquet time and more graft sources. This is the difference than a single ACL and single PCL reconstruction. If allograft is available for PCL, ACL is reconstructed with autografts as in the usual manner. This is the method I use, steps. A standard arthroscopic portal. I start with a diagnostic arthroscopy and create a posterior medial portal for PCL management, and tibial tunnel for PCL under C-arm control always. Outside in femoral tunnel for PCL. ACL tunnels in the usual manner, and fixation of femoral tunnels for PCL and ACL. Afterwards, I fixate PCL in 90 degrees of knee flexion and fixate ACL in near extension. So which graft should we use? Allografts and autografts have all been reported in the literature. For PCL, we need a thicker graft than ACL, not less than 9 or mostly 10 millimeters in diameter. So if we have allograft options, it's better for us. It's easier. But if you don't have allograft sources, you can use autografts as well, like bone patellar tendon, bone hamstrings, quadriceps tendon, and peroneus longus for both reconstructions. And this depends on surgeon's experience, actually, availability and preference. So which fixation should be first? Historically, PCL graft is first fixated at 70 to 90 degrees of flexion in the literature, but controversial options also exist in the literature. I prefer to fixate PCL first in 90 degrees of flexion. This is the operative technique I use. This is the steps, patient position, tendon harvesting, tunnels, and arthroscopic technique I'd like to summarize. This is my position. I put the other leg to the side because I need the C-arm above this leg. So I need a distance, I need a room. Then you need the extra distance behind the knee here because we create the posterior medial portal to work. So we need a distance here. So we take a little bit further to the patient. And this is of my patient, and I examine under anesthesia all patients. Like here, I see the laxity in both directions and make sure that collaterals are intact. So I prefer to use peroneus longus tendon as an autograft source, as well as hamstrings, because peroneus tendon harvesting is easy. And it's very less downside morbidity, no foot and ankle disturbance so far, and long tendon that you can harvest. So you can see here, there is a short incision like 2 centimeters just behind the fibula. And under the skin, you can find easily peroneus longus tendon here. Then with the open stripper, I take the tendon. Mostly not less than 25 centimeters. And I then I start arthroscopic, diagnostic arthroscopy, and first I create a tibial tunnel for PCL under C-arm control, always under C-arm control. I don't trust the visualization with camera. I always like to see where I am in the bone. So this is my operation. Left side is ACL remnant. I clear up ACL, shave off. Right side here is the PCL. PCL seems intact, but actually never see a ruptured PCL. Always loose, but still there. So I keep PCL remnant. I don't shave off PCL. I keep it the remnant. So I go posterior medially here behind the knee with the camera. From the lateral portal, I see with my finger, I feel it, then send a needle to create a posterior medial portal here. And with an instrument, I open the posterior medial portal here. I use this portal not for seeing. I use it for management of the tendon and to shaving. Then I use the creation of the femoral tunnel from outside in technique. I send the K-wire, then open, drill the tunnel. Then from the tibial tunnel, I take the sutures from tibial tunnel to the femoral tunnel. Then I pull my tendon up. Then I fix it with a bias screw. I like to see the screw inside the joint like this. Then femoral fixation is over. Then I fixate femoral side of ACL graft. I pull it up. I use suspensory fixation system on the femur for ACL. Adjust the length. Then I pull the tendon up, fixate it. Afterwards, after fixation of the tibial sides of both tendons, I check the tension, and check the range of motion if there's any impingement during extension and flexion. I like to see smooth range of motion without any impingement for both tendons, as in here. So then I examine the patient afterwards, like here. Make sure that both directions are good enough. And what literature says to us, there are a couple of publications mentioning both ACL and PCL reconstruction in same setting without any collateral reconstructions. Multiple options we have: autografts, allografts, fixation system, depends on the surgeon, but autograft patellar tendon for PCL is used in one publication, and hamstrings for ACL says that autografts are effective in restoring knee functions. Another publication used allografts and autografts and compared them. There's no difference in knee function and stability between allografts and autografts, and they all restored knee functions. Another publication, ipsilateral and contralateral autograft hamstring tendons have been used, and it says autograft hamstring tendons are reliable for restoration knee stability. I prefer to use same knee, harvesting hamstrings and peroneus longus at the same knee. But if there's any condition like revision cases, I sometimes take contralateral knee hamstrings too. In summary, single-stage ACL and PCL reconstruction can restore knee functions. Post-op rehabilitation is essential for functional improvement. And if we have enough autograft sources, we can use autograft for both ACL and PCL at the same time. To prevent complication, we should use a good surgical algorithm for each time, and we should be careful working behind the knee. Thank you very much.